62-year-old man presenting with right-sided weakness and dysarthria in the early morning. He was normal when he went to bed. He got up at 4 a.m. to find that he has got weakness of the right side of the body. Patient was immediately taken to hospital. GRBS was normal and a non-contrast CT scan was done. We showed no hemorrhages, acute ischemic changes or hypertensive vessel sign. His NIHS score was 8 and had a disabling stroke. The question is, next step in the management. Option A, CT angiography. Option B, MRI, diffusion weighted imaging, flare mismatch. 3, mechanical thrombectomy. D, IV rtPA, that is thrombolysis. Before going into the details of management, let us see what is the problem. This is called wake-up stroke. 20 to 25% of people with stroke notice stroke in the early morning. The risk factors and clinical features are almost same, but this is more common in the elderly. Little more, the age group is different, and the strokes are less disabling compared to a stroke with a non-onset. That is only difference. And these cases are usually not considered for thrombolysis because in the trials they were not included. But later people found that many of these stroke patients, the stroke occurred a few hours before waking up. And for this, the time of stroke and salvageable brain can be identified by going by the diffusion weighted imaging with the flare mismatch. So here you can see this is the diffusion weighted imaging where you can see an area of ischemia, and here the flare image, there is no lesions are found. This is what is called diffusion weighted imaging flare mismatch. That is, in the diffusion weighted image you are seeing the abnormality, and the flare image you are not seeing it. Such cases these are eligible for IV thrombolysis. And the below picture you can see this is the diffusion weighted imaging and this is the flare imaging. Both shows the abnormalities, and there is no mismatch here, and such cases are not eligible for thrombolysis. So a patient comes with a wake-up stroke and comes reasonably in time. That is around 4.5 hours after the onset of the or finding out the stroke. Such cases, if the onset time is not known, you can go for a diffusion weighted imaging flare mismatch, identify whether the brain is salvageable and can be taken up for thrombolysis. Let us go into the American Heart Association guidelines for the indications of IV thrombolysis. The newer addition is the wake-up stroke with the diffusion weighted imaging flare mismatch on MRI. All others are remaining same. That is age more than 18 years. The onset of symptom within 4.5 hours and ischemic stroke which is disabling rather than the severity. For example, somebody with aphasia, even though the deficit is less, this is a disabling one, and so patient should be considered for thrombolysis. Same is the homonymous hemianopia, especially for a driver or a professional. This is a disabling thing. So that is the changes in the American Heart Association guidelines for IV thrombolysis. We just quickly go into the contraindications. Severe head trauma or ischemic stroke within the last 3 months is a contraindication. At any time, intracranial hemorrhage is a contraindication. Subarachnoid hemorrhage you should not do. Infected endocarditis suspected, dissection, absolute contraindications. And recent intracranial or intraspinal surgery within 3 months, again contraindication. Somebody has got a intracranial neoplasm, gastrointestinal malignancy or upper GI bleed or any GI bleed during the last 21 days. Active internal bleeding. Regarding hypertension, we have already mentioned systolic blood pressure more than 185 and diastolic more than 110, and if it cannot be lowered is a contraindication. This last time we have discussed. Any bleeding diathesis is a contraindication. So if the INR is more than 1.7, patient should not be taken up. Patient has found heparin within 48 hours and APTT is high, should not take up. Patient is on low molecular weight heparin during the last 24 hours. Absolute contraindication. Platelet count less than 1 lakh. Current use of direct thrombin inhibitor or factor 10A inhibitor again considered as a contraindication. So the patient is on newer anticoagulants. Oral anticoagulants again contraindicated. Of course, CT showing hemorrhage is a contraindication, and CT scan showing extensive hyperdensity more than 1/3 of a cerebral hemisphere. That is how it should be 1/3 of a hemisphere is again contraindication. So we have now the newer guidelines. The different imaging approaches can be utilized for considering thrombolysis. Two important techniques are, one is the penumbral imaging and diffusion weighted imaging flare mismatch. We have discussed about the diffusion weighted imaging flare mismatch.